Hello and welcome. Today we're diving into a fascinating and often overlooked condition affecting the kidneys, type 4 renal tubular acidosis, also known as hyperkalemic renal tubular acidosis. We'll explore what causes it, how it affects the body, and what can be done about it. Type 4 RT arises from a deficiency or resistance to the hormone aldosterone. This hormone plays a crucial role in regulating sodium and potassium levels in the kidneys. Common causes include diabetic nephropathy, a kidney disease caused by diabetes, interstitial nephritis, and inflammation of the kidney's tubules and surrounding tissues, and certain medications like ACE inhibitors, ARBs, and potassium-sparing diuretics. Less common causes are adrenal insufficiency, which hinders aldosterone production, and congenital adrenal hyperplasia, a genetic condition affecting the adrenal glands. Now, let's understand the pathophysiology. Aldosterone normally stimulates the kidneys to reabsorb sodium and excrete potassium. In type 4 RTA, due to aldosterone deficiency or resistance, the kidneys retain sodium, leading to decreased potassium excretion. This results in hyperkalemia, or high potassium levels in the blood. Additionally, the impaired sodium reabsorption hinders hydrogen ion excretion, leading to metabolic acidosis, where the blood becomes too acidic. This combination of hyperkalemia and metabolic acidosis is characteristic of type 4 RTA. Determining the precise epidemiology of type 4 RTA can be challenging, as it often occurs alongside other underlying conditions, such as diabetes. It is more prevalent in individuals with diabetic nephropathy, affecting a significant portion of those patients. The incidence also increases with age, and in populations with higher rates of diabetes and chronic kidney disease. The signs and symptoms of type 4 RTA can be subtle and vary depending on the severity of the condition. Mild hyperkalemia might be asymptomatic, but as potassium levels rise, individuals may experience muscle weakness, fatigue, and cardiac arrhythmias. Metabolic acidosis can lead to nausea, vomiting, and a general feeling of being unwell. In severe cases, hyperkalemia can be life-threatening, causing cardiac arrest. Diagnosis of type 4 RTA typically involves a combination of blood and urine tests. Blood tests will reveal hyperkalemia and metabolic acidosis, usually characterized by a low bicarbonate level. Urine electrolyte analysis can help assess the kidney's ability to excrete potassium and acid. An aldosterone level measurement can help differentiate between aldosterone deficiency and resistance. Further testing to identify the underlying cause, such as kidney biopsy in some cases of interstitial nephritis, may also be necessary. While there aren't distinct subtypes within type 4 RTA itself, it is crucial to classify the underlying etiology to guide treatment effectively. For instance, differentiating between diabetic nephropathy-induced RTA versus drug-induced RTA alters the management strategy. The primary goals of treatment are to correct hyperkalemia and metabolic acidosis. Dietary modifications, such as limiting potassium intake, are often recommended. Medications that lower potassium levels, like sodium polystyrene sulfonate or patchomer, may be prescribed. In some cases, a mineralocorticoid replacement therapy, such as fludrocortisone, can be used to increase aldosterone activity. Addressing the underlying cause, such as optimizing blood sugar control in diabetic nephropathy or discontinuing offending medications, is crucial for long-term management. Preventing type 4 RTA largely focuses on managing the underlying conditions that can lead to it. For individuals with diabetes, maintaining optimal blood sugar control is paramount. Regular kidney function monitoring, particularly in those at risk, can help detect early signs of RTA. Careful medication management and avoiding potassium-sparing diuretics in susceptible individuals are also essential preventive measures. The prognosis for type 4 RTA depends on the underlying cause and the severity of the condition. With prompt diagnosis and appropriate treatment, many individuals can effectively manage their symptoms and prevent complications. However, untreated or poorly managed type 4 RTA can lead to life-threatening cardiac arrhythmias. Recent research is focusing on developing more targeted therapies to enhance potassium excretion and improve long-term kidney function in individuals with RTA.